Auzubillahiminash-shaytanir-rajeem. Bismillahir-rahmanir-rahim. Ar-Rahman allama al-Quran khalaqal insana allamahul bayan. हमेशा की तरह शुरू करने से पहले अच्छी बात याद रहे, it's not the wealth one asks for, but just enough to preserve one's dignity, to work unhampered, to be generous, frank and independent. Or important is success is hidden in your daily routine. याद रहे आपने ना डिसिप्लिन इज़ इम्पॉर्टेंट फॉर गेटिंग सक्सेस. इट्स नॉट कि एक दिन आपने बहुत सारी पढ़ाई की अगले हफ्ता नहीं की. सो आपने एक डिसिप्लिन रखना है. 5 days अ वीक आपने मेहनत करनी है, हफ्ता इतवार रिलैक्स करना है. सो यू हैव टू कंटिन्यू दिस लाइफ फॉर अ लॉन्ग टाइम. सो आज के ये जो लास्ट टॉपिक है शॉर्ट केसेस का, ये है टॉल स्टेचर. टॉल स्टेचर कमांड होगी कि दिस इज़ द थिन चाइल्ड टॉल चाइल्ड डू द जीपी एंड रेलिवेंट. So after introduction and consent, you do the hand sanitization and exposure. Ideally, there will be single shot, but you have to take into consideration about the weather and the modesty. Then there are observations. For before starting, this is a basic thing that you have to see whether the child is sick, well looking, sanos or respiratory distress at rest. What is the pallor, jaundice or nutrition status or any diagnostic or dysmorphic features. So you just start this case by greeting and ask the name of the child. So this will tell you about the mental status, because in Soto's homocystinuria and Beckwith-Whiteman syndrome there's a low IQ. Then you have to look at the body habitus of the child. Stand and back to look for enochoid habitus which is present in Klinefelter or Calvin syndrome. Marfanoid body habitus, neurocutaneous stigmata, like which occurs in cafe au lait, spots and neurofibromatosis type 1 McCune-Albright syndrome, hemiplegic gait, which is in a CVA in a hemocystinuria, and Marfan about the hemiplegic gait, which shows a CVA in hemocystinuria. Then the Marfan facies in which there is a dolichocephalic head shape, retrognathia, and the malar hypoplasia. After these observations, you go for the measurements. You measure the upper segment and then the lower segment, and then you check the ratio, because upper segment to lower segment ratio is decreased, in which the upper segment is relatively longer, because the lower limbs are short. For example, in morphinoid and uniconoid habitus, lower limbs are disproportionately long. Then upper segment to lower segment ratio is normal. It occurs in the familial tall stature or pituitary gigantism. And then the arm spans. Increased arm span to height ratio greater than 1.05 occurs in the Marfan syndrome. Then measure the occipitofrontal circumference and request birth weight. Sotos and Beckwith-Whiteman have large birth weight. Then after observation, measurements go for the maneuvers. First, hands and feet together to check for the hemihypertrophy, which occurs in Beckwith-Whiteman syndrome, Proteus McCune-Albright syndrome, then genu valgum of homocystinuria, then genu recurvatum and pes planus in Marfan syndrome. Then you tell the child to bend over and touch toes, which shows the scoliosis in Marfan syndrome, neurofibromatosis 1 in homocystinuria. Then wrist and thumb signs. Thumb sign is called Steinberg sign. Wrist sign is vocal Mudrock sign. Then systemic examination. You do from the head to toe. Head is large in Soto syndrome and small in Beckwith-Whiteman syndrome. There will be large spots here in homocystinuria. Then eyes, glasses due myopia in Marfan syndrome, homocystinuria. The dislocation of lens in Marfan is above and in homocystinuria is down. You can memorize it because Marfan is a moon and moon is up. So lens dislocates upwards and homocystinuria H is hell, H is downward. Then hypertelorism, the downward slanting eyes in the Soto syndrome. Fundoscopy in the retinal detachment in Marfan syndrome. Cataract in homocystinuria. Glaucoma in Marfan's and homocystinuria. Then exophthalmos, which occurs in hyperthyroidism. Then check the ears. There will be pits in the pinna and back with Weidman syndrome. Mouth, crowding in homocystinuria, and the cleft palate will be in Marfan syndrome. Large tongue will be in pituitary gigantism and back with Weidman syndrome. Then you check the neck for the goiter, chest, chest for pectus excavatum and carinatum, which is in Marfan syndrome, cardiovascular system for mitral valve prolapse and aortic regurg, which occurs in Marfan syndrome, abdomen for adrenal mass, Wilms tumor, and Beckwith Weidman syndrome, scar for omphalocele surgery, Tanner staging, which will be delayed in Klinefelter and Kalman syndrome, and advance in congenital adrenal hyperplasia and adrenal tumor. At the end of examination, ask for the gait and lower limb examination. Finish the examination by saying, I want to do fundoscopy, plot height and weight, and FOC on centile charts. I have made a hypothetical description. You can make your own, but do practice it. Assalamu alaikum, sir or madam. I have just examined 7 years old Junaid, who was conscious and cooperative during my examination. He is well looking child without respiratory distress or cyanosis at rest. There is no pallor or jaundice. The nutrition status is adequate and there are no diagnostic or dysmorphic features. He seems taller than his age with uniconoid body habitus. His height is 170 centimeter, upper segment is 70 centimeter, and lower segment is 100 centimeter, with the ratio of upper segment to lower segment of 0.7, sorry. Arm span of 180 centimeter, FOC 60 centimeter, and weight of 30 kg. His geno recurvatum and wrist and hand signs are present. His pulse is 80 per minute, respiratory rate of 15 per minute, and is afebrile to touch. He is wearing glasses with repaired cleft lip mark, and Tanner staging is prepubertal. There is no genu valgum, scoliosis, no clubbing pallor, retinopathy, no cataract, no pits on ear, no neck swelling. The shape of the chest is normal, with normal heart sounds. The abdominal and gait examination is normal. I want to take blood pressure, plot height, weight, and FOC on centile charts, and do the fundoscopy and detailed eye examination. So let's tell you something about the normal values. Upper segment to lower segment ratio at birth is 1.7. 3 years it's 1.3. At 8 years it's 1, and in 18 years it's 0.9. Arm span from birth till 10 years is 0 to 3 centimeter. 8 years minus height, 8 years to 12 years it's 0 centimeter, and 14 years plus the difference between arm span and height is plus 1 centimeter in girls and 4 centimeter in boys. So some of the causes of tall stature, which can be familial, in which upper segment, lower segment is normal, Klinefelter, Marfan, homocystinuria, precocious puberty, Soter syndrome, pituitary gigantism, neurofibromatosis, hyperthyroidism. Marfan syndrome, something about it, it's an autosomal dominant disorder, and there will be fibrillin gene mutation, urinary cyanide nitroposide test will be positive, cystathione synthetase deficiency test, urine for amino acid screening, which can be in homocystinuria, echo, and chest x-ray. So management of Marfan is you have to restrict the activity, avoid strenuous exercise to avoid aortic dissection and retinal detachment. Aortic dissection surgery if aortic root dilatation is greater than 50 millimeter, or if a rate of dilatation is more than 5 to 10 millimeter per year. Drugs are used such as ACE inhibitors, calcium and beta channel blockers. And recent advances, the losartan decreased the rate of aortic root dilatation, and TGF-B neutralizing antibody. So genetic counseling, it is an autosomal dominant disorder, and 15 to 30% are first affected in family, so history cannot be positive always. So this is a picture of a Marfan syndrome child copied, homocystinuria. This is the Soto syndrome facial features. This is a bag with Weidman syndrome. Look at the hem, macroglossia, and large tongue. Then these are the uniconoid proportions. So A is the upper segment, B is the lower segment. So lower segment is more than the upper segment. arm span is more than the upper segment. And then this is the Marfan syndrome, eye findings. Then these are the wrist sign, Walker Mother sign, and the Steinberg or the thumb sign. This also the chest deformity of the Marfan syndrome. Then in Klinefelter syndrome, there is an extra chromosome, X chromosome, and these are the cafe au lait spots in McCune-Albright syndrome. So, Alhamdulillah, that I have finished the all the short cases that you can memorize, and you can add different short cases in it. And I'm waiting for your suggestions to tell me what to start next. And please do message me on my WhatsApp number. So there are options are there, so that we should do the theory, like different topics. I'll tell you different topics I like to make it easy for you, or make an MCQs for you, or a live sessions of questions and answers, where I will be telling you the live something about the academic topics. So thank you very much, and do write to me, do WhatsApp me, and inshallah we'll come again. And I pray that may Allah be our helper, protector, and guide. Best wishes for you. Allah Hafiz.